All right, let's get started. Good morning, good afternoon, and good evening, wherever you are. Welcome to the Duke Global Health Institute webinar series, Global Challenges and the COVID Vaccine. Every month since January 2021, the Duke Global Health Institute has invited global and local leaders to speak about the COVID-19 vaccine, vaccine equity, vaccine hesitancy, financing, manufacturing, IP, supply chain, and today we are delighted to present a diverse range of experts to discuss the rollout of COVID-19 vaccines on the African continent. My name is Kearsley Stewart, faculty here at DGHI, and I'll be introducing our moderator, Dr. Krishna Udayakumar, and also offering some housekeeping notes. As with the previous 4 webinars, this series is recorded and will be made available on our Duke Global Health Institute website within a day or so. We will also send everyone who registered for the webinar an email link to the recording. I'll be moderating the Q&A chat, so please do post your questions for our panelists, as we have left plenty of time to address your questions and queries. I'd like to introduce our moderator, Dr. Krishna Udayakumar, who will open the session with updates and then engage our panelists in conversation. Dr. Udayakumar is an associate professor of global health and medicine here at Duke, and he is also the founding director of the Duke Global Health Innovation Center, and most recently the principal investigator of the Launch and Scale Speedometer project, which is supported by DGHI and the Gates Foundation. The Speedometer initiative collects high-quality data on scaling up health interventions and is now globally recognized as one of the leading resources of data for the COVID-19 pandemic, including vaccine candidates, procurement, and manufacturing, all with an eye to understanding vaccine equity challenges. Let me hand it over to you, Krishna.
Great, thank you, Carrie. Welcome, everyone. Such a pleasure to join you all and have this distinguished panel of discussants to lead us through a conversation today. I want to take just about 5 minutes to set the scene, because we're going to be talking about what the COVID pandemic has looked like across the African continent, as well as the position we find ourselves in terms of access to vaccines. I'm waiting for the next slide to come up here. The first thing we'll see is really that the toll of COVID has continued to be significant globally. So if we look, we know that we're over 163 million cases and almost 3.4 million deaths around the world. And if we see the distribution on this map here, what stands out really is relative to other regions that the African continent has done fairly well, and that's part of what we want to dive into today in understanding lessons learned. We also know, if you look here, that the pandemic has been extremely dynamic in nature, that it hasn't really just come and gone in any region. You see in both of these charts the deaths that have happened over the last 15 months or so, represented on the left-hand side on a time axis with different regions of the world. And on the right-hand side, you see the same data represented by income category with the time axis as well. What I'd like to point out here is that you'll see that after the first significant wave in China, that the next real death rates occurred across high-income countries, largely in Europe. Then we saw upper middle-income countries, even lower middle-income countries. Again, if you look at the bottom left here, what you'll see is that the rates of death across Africa have stayed relatively modest. Again, you'll see how it's done compared with the rest of the world. So with that context in mind, let's shift to where we are in terms of vaccines and access in Africa. What we are showing here is our own data from the Launch and Scale Speedometer in terms of the purchases of vaccines both by income category as well as by country. And what stands out starkly here are the growing inequities in terms of access and equity in vaccines around the world. If you look at purchases by income category, you'll see that high income countries, which have about 16% of the world's population, have bought more than half of all of the vaccine purchases that have been made. And if you look at this map on the right, you can see clearly that population coverage is lacking in certainly across Africa, but also across Asia and Latin America. And then if we end with a lens of not just where the purchases have happened, but where the actual vaccinations have happened, we are all about to hit 1.5 billion doses of vaccines administered in 176 countries around the world, of which COVAX, which we'll talk about in more detail as we go, has to date shipped out 67 million doses to over 120 participants. So you'll see that the COVAX, which we all aspire to be a major global player in terms of access and equity, has distributed a relatively modest number of doses relative to overall what's been purchased and distributed on a bilateral basis. And if you look at the map, you'll see again the distribution and the stark inequities. And the final part I'd leave you with is if we look at different regions on the right-hand side, we are in a quite fortunate position here in the US, where we're talking about almost 50% of the population having at least a dose of vaccine. In North America, across the continent, about 33% have at least one dose of vaccine. And you'll see that across the African continent, that's less than 2% of the population with access to at least a single dose of vaccine. So we see that overall, there's this dichotomy that Africa has done relatively well in terms of its response to the COVID pandemic, and yet we see the stark and growing inequities in terms of access to vaccines, and that's what we want to unpack a little bit as we go today. And to help me do that, we've got an incredible set of speakers here. I'll just introduce, as you see on the screen here, we've got Richard Hatchet, who serves as the CEO of the Coalition for Epidemic Preparedness Innovations, one of the real highlights and shining stars of our global response. We've also got Dr. Nike Sindembi, who is the Senior Science Advisor for the Africa CDC, and again, representing a relatively young but high-performing organization in Africa CDC. We've got Dr. Bartholomew Akinmori, who is part of the Regional Office for Africa at the World Health Organization. We've got Dr. Rashida Farhan, who is a professor of international health clinical research at the London School of Hygiene and Tropical Medicine and is based in Zimbabwe. And finally, we've got Dr. Isaac Omeri, who's the Chief Officer of Health for Busia County in Kenya. So fantastic perspectives, and let's dive right into it. I'm going to start by bringing in Dr. Omeri to help us understand really at a grassroots level what is happening on the ground. So Dr. Omeri, if you can just tell us briefly about Busia County, what's happening in terms of COVID, and do you have vaccines? When do you expect them?
Yeah, thank you so much, Dr. Krishna. This is quite appreciated that you've given us an opportunity to give a picture of how things are here in Kenya, especially Busia. Busia is one of the counties of Kenya. We have got 47 counties, and Busia County borders Uganda on the western part of Kenya. It is a small county. We have a population of around 980,000 people. So far, we've had people affected by COVID. We have tested 118,000 people tested for COVID. And out of this, we have found like 3,600. Okay, 3,600 have been positive. Unfortunately, we have lost 8 people. We have an isolation center, and we have got 7 hospitals within this county that are managing COVID, but the main hospital is Alupe Sub-County Hospital, which manages COVID as an isolation center. I also want to say that we received our batch of COVID vaccination from the AstraZeneca in March, and the vaccination in Busia County was launched on 9th of March. And up to date, we have vaccinated close to 9,400. We have only vaccinated mostly people have received the first dose. It was from the advice by the World Health Organization and the rest of the authorities that people can get the second dose after 12 weeks, not necessarily 8 weeks as had been anticipated before. So most of our people have got the first doses, and we are still having a balance of around 2,700 doses of the AstraZeneca vaccine. I must say that we have so far vaccinated a number of healthcare workers, around 2,387. We have also vaccinated security officers, around 798. We have vaccinated teachers, 1,800, elderly people and others, about 2,890. And the general population, we have given 1,519. So far, that is the status where we are. And of course, we have a number of challenges that are still in existence. One, the uncertainty of the next doses. I think that's what is really eating up the people. And also there was a problem of, first of all, the views about vaccination. It took us time to let people know that, yes, the vaccine is safe. We started by I myself getting the vaccination, and my deputy governor, Honorable Mlomi, we got the vaccination, and other senior people got the vaccination, and that's when we instilled trust in the people. Generally, that's where we are as a county, and of course, we shall maybe in a later time discuss about challenges, but the challenges were mostly, if we have to look at them in brief, is we had a problem of human resource. We had to train our people. COVID is a new disease, and we had to tell our people how to train our healthcare workers. 2, we had to spread health education to the population. First of all, to make them accept the vaccine, and then the logistic issues. It comes without adequate funds. You need to move around. You need to do all those things. Sometimes we find that we are given vaccines, but then we have to use resources that we had meant for other purposes to carry out the vaccination of these people. And of course, that also storage facilities in terms of the temperatures that are acceptable for vaccine storage were a challenge. But generally, people have accepted the vaccines. In fact, now the challenge we are facing is how to get more of the vaccines. Thank you so much.
Thank you, Dr. O'Mary. That was a highly insightful perspective on what's happening in Busia. Thank you for your leadership there to both manage the pandemic and get, seems to be at least the first round of vaccinations out in an efficient way. Let's turn now to the situation on the ground in Zimbabwe and bring in Dr. Farhan. Dr. Farhan, thank you for joining us. Please give us a sense of what's happening on the ground, what's life like, and what is the sense of vaccines now and access going forward?
Thanks, Krishna, and thank you for inviting me to be part of this panel. Real privilege to be here. So Zimbabwe is a country of about 13 million people located in Southern Africa, and it's a landlocked country bordered by South Africa, Botswana, Namibia, Zambia, and Mozambique. So that a lot of our epidemic here reflects what often happens in South Africa. And we've had two large waves of the epidemic. The first one was last year, and the second one sort of started in December and sort of abated around March. And that very much was sort of exacerbated by the variant that originated in South Africa, which had really quite fast transmission, and the cases have abated. So currently we're seeing roughly about 20 to 25 cases a day. We've conducted approximately 600,000 odd tests, which is a combination of antigen, rapid antigen tests, PCRs, etc. In terms of the actual numbers, we in total to date since the pandemic began, we have seen just under 40,000 cases, about 38,000 cases, and 1,500 deaths. And that sort of, pales in comparison in terms of the numbers that have been observed in the global north. We've basically, in terms of vaccination, have received largely vaccines from China, which is the Sinovac and the Sinopharm. And we started vaccinating about a month and a half ago, and we've really had about just under 600,000 vaccine doses given in total of the first dose, and about just under 200,000, 192,000 second vaccine doses. So currently, the numbers of new cases is around 20 to 25 new cases a day. And the cases have largely been restricted to the two big urban cities, which is Harare and Bulawayo, and Matabeleland, South Province, which borders Botswana and South Africa. So currently, in terms of vaccine dosages, the numbers being delivered is rapidly increasing. We've seen a recent steep rise in uptake just because there's more comfort and more confidence coming in, but we're nowhere near to kind of reaching high population level coverage of either the first or the second dose. But some of what was said by Dr. Isaac, I would also echo, would be on the ground, that clearly we've been able to use the very well-established EPI program to kind of use as a template for delivery of vaccine, and it kicked off very quickly. However, there are extremely large logistic challenges that remain in terms of operationalizing delivery of vaccine for universal use, which will include not only just maintenance of cold chain supplies, but also transporting the vaccines, having trained healthcare workers, appropriate messaging, and ensuring that there's a steady supply of vaccine doses, both for the first and the second round of vaccines. Over. Thank you.
Great, thank you so much. And what do you see going forward in terms of ongoing access to vaccines? And if you could tell us a bit more about what you're seeing in terms of vaccine confidence or hesitancy, especially with access to the Chinese vaccines there.
Yeah, I mean, there is definitely a degree of vaccine hesitancy across the population, and with all due respect, the fact that a vaccine comes from one part of the world in one country has been one factor in contributing to vaccine hesitancy. There have been questions asked, particularly because there was no RCT data when the vaccine was brought into the country, as to why we were using the Sinopharm and later on the Sinovac vaccine. Having said that, the numbers of people taking up vaccines has increased, but those questions still remain. It's been reassuring that the Sinopharm vaccine recently received WHO qualification, but there's still sort of FDA European regulations to negotiate, and the Sinovac still awaits approval. And I think obtaining WHO approval will and is likely making a difference in terms of overcoming the skepticism that exists about this particular vaccine. There is a lot of sensitivity around the COVAX initiative in this country, which I'd be happy to discuss. But currently, our vaccines are largely from China. We had some access to the vaccines from India, but that has recently been halted in the light of the terrible circumstances and the rise in the COVID cases in India. But we do remain, just as Dr. Isaac has said, very concerned about the durability of the vaccine access, and particularly if it happens that there are requirements for further booster doses, or indeed a different vaccine should variants arise. Over.
Great, thank you so much, Dr. Farhan. We're going to now move from these two country level perspectives or subnational perspectives even up to what's happening on a regional perspective. And for that, I want to bring in Dr. Ndembi as the Senior Science Advisor for the Africa CDC. Dr. Ndembi, I believe you have a few slides you'd like to share as well. But again, as I mentioned early, the Africa CDC has been a shining light of a young but very capable organization that has really helped lead the way for the continent, but also for the world in addressing some of the key challenges here with the pandemic. So Dr. Ndembi, I'll turn it over to you to share with us your perspectives.
Hello?
Yes, we can hear you.
Good, good. Thanks so much. I think you've really, the two previous speakers have said to my presentation at least. I'm going to provide just a quick overview, very few slides here to really crystallize our discussions around what we really need here. So we're all familiar with this, the statement, the US aimed at vaccinating about 80% of the American population to reach herd immunity, China 70 to 80, Italy at least 80% of the population. So from the Africa CDC perspective, we set a target around at least 60%, vaccinate at least 60% of the eligible population. So this slide provide kind of a shocking disparity in terms of vaccine deployment. If you look at where we are in terms of the number of doses administered per 100 people, we're still at 1.7 compared to the global average around 19 doses administered per 100 people. I think that there's a significant progress, at least from where we're coming from for the past couple of months, but there's still a lot to do in terms of rollout of COVID-19 vaccine on the continent. I think we've so much probably dwelled on the acquisitions in the past couple of weeks, but now it's time probably to look at the uptake. I think I've been also happy to see that the previous speakers have alluded to this. So this slide, it's a very clear illustration that there's a lot of work to do around community engagement and risk communications, where we have over 10 countries with doses at risk of expiring before being administered. That is one. Second, the other picture that you can see through here, it's like the situation around the AstraZeneca vaccines, where member states are holding at least the vaccine to be sure that those that have received their first doses can be have a second dose when they are scheduled. So that's really a contrasting picture that you can see here. But at least we have at least 10 countries with vaccines at least expiring before being administered in the next couple of days. So in line of community engagement in vaccine hesitancy, vaccine perception, what we did at least before the rollout was to conduct a continental survey in 15 countries, over 15,000 respondents in collaboration with the London School of Hygiene and Tropical Medicine. So it's quite clear, it's summary, and what we're also seeing from data that are coming out now is that initially we had at least 1 in 5 respondents say they will, 4 out of 5 said they will take a safe and efficacious vaccine when it becomes available. But these pictures are completely changed when the vaccines started arriving into the member state. I think this data also is quite similar to what we have from the Janssen project on vaccine hesitancy in Africa, at least for Ethiopia, Nigeria, DRC. So in terms of visibility, what we did was to provide, we have a live dashboard available on our website where we track actually vaccine administered to the COVAX facility, the bilateral deals, and then the African Union initiative. I think I really want to emphasize here that we work in a very complementary way with the COVAX facility to ensure that we reach our target in terms of vaccinating at least 60% of the African population. So again, in terms of providing visibility, quite important because we really want to understand what's happening in those 10 countries in terms of vaccine expiration. So we're trying to now to set up a dashboard, a visibility dashboard with the 3 streams to be able to track those vaccines and then also the absorption and uptake at country level and propose solution and interventions when needed. So where are we? Over 24 million doses have been administered in 49 countries. And then I think as of yesterday, I think, but we still have countries that we're really trying also to ensure that they have access so no one is left behind. There are countries that are still have not really even ordered or claimed their allocation through the AU platform or through the COVAX facility and even through bilateral deals. So in terms of percentage coverage, if we put in our target to 60%, as I mentioned earlier, 34 countries achieve less than 1%, 13 countries between 1 to 10, and then Morocco and Seychelles have at least achieved over 10% and 64% of Seychelles. So I think this slide is quite important to us as we move forward in the discussions. I think we've made a case for vaccines through the COVAX facility, through bilateral deals, the African Union, and also now through probably the G7. Now, there's a key component, if you've seen in my previous slide, vaccinations. It's not happening at the, I think, at the scale that we have really anticipated. I think there are quite few issues there, the facility, the personnel, the supplies, the IT infrastructure, and again, community engagement that we need to look into so as to ensure that we save lives of the 1.3 billion people that we really take care of. So I think we've alluded to this. I think it's a challenge, a global challenge in terms of supplies, but they anticipated at least delivery by the end of May was about 75 million doses of AstraZeneca to the COVAX facility, and then the Pfizer vaccine. But we all know that's quite challenging right now, given the situation that we have at hand in India. So I think at that time, given the projections, and by the end of June, we had a gap that we anticipate to have at least a gap to close a gap of 45 million doses so as to achieve 60% target by 2022. So this is quite challenging at this point, given what I've raised in my previous slide. But the point here is to be able to ensure that we have a diversified portfolio through different mechanisms to be able to achieve our target. I think working through the African Union initiative, we've secured over 400 million doses, 220 million doses secured, and with an option of 180 million doses through, from Johnson & Johnson, and also engaging different vaccine manufacturers to ensure that we have a diversified portfolio. To one, cover that access that I did mention, and also financing. To Africa Bank, we've been able to secure $2 billion to be able to achieve that. I think I will leave you with some critical challenges. The low uptake, I think the presenter from Kenya did mention. Countries are saving second dose for first dose recipient. That's a challenge at hand. Now the logistics, I did mention already, and we have seen that from the uptake. And then we haven't touched base on that yet, but the influence and of the mutant and the vaccines, the variants of consent on vaccine efficacy. I think this is how it looks like if you look at that on the efficacy And if we plan to achieve that herd immunity, and you look where we are, we stand to look at least achieving that herd immunity with a coverage as well, will require that we have vaccines with high efficacy and in the context of really no variant, which is quite difficult because we have already had more than 100 countries have at least reported one or two variant in co-circulation. This actually has an impact on the reduced efficacy of those vaccines that are available. And henceforth, they need to conduct some of these vaccine effectiveness study to ensure that we monitor closely what's going on in real life. So lastly, the key critical and take-home vaccine acquisition, closing the gap I did mention, working hand in hand with the COVAX facility. Then second, the vaccine deployment, which is quite challenging at this point. The plan is to be able to also provide some technical support and capacity building to member states to be able to increase their absorption rate. Thanks, and over to you.
Thank you so much, Dr. Ndembi. That was a fantastic overview of where we are across the continent, some of the key challenges. Can I ask in follow-up, if you could speak a bit more? You mentioned that you're working closely with COVAX on acquisition, as well as through the AVAT platform in a complementary way. How do you see those coming together, and what was the impetus for launching the AVAT platform and looking at pooled procurement as a complementary model?
No, I think for sure, if we want to meet our 60% target, we need to reach first to 27%. That's why our support, the support from the COVAX facility is really instrumental. So we set that really ambitious target to vaccinate at least 60%. And then that aim was riding on the existing support from the COVAX facility. So we wouldn't have been able to achieve that if we didn't raise our that AU initiative I did mention, the Africa Vaccines established the Africa Vaccine Acquisition Task Team. That's basically why we're working hand in hand. We have a monthly meeting with Gavi and even having an MOU with CEPI to ensure that issues around vaccines and vaccine equity have been, that gap has been closed. Thank you, and over to you.
Great, thank you, Dr. Ndembi. And now I want to keep bringing us up and looking at the global view. And for that, I want to bring in Dr. Hatchet, who's the CEO of CEPI, another young but high-performing organization. Dr. Hatchet, thank you for joining us. If you can maybe just give us a 1 or 2 minute perspective on what is CEPI, what was the impetus of creating it, and how has it responded in helping lead the charge in the global response to COVID-19 and specifically around COVAX.
Sure, no, thanks, Krishna, and thanks to the Duke Global Health Institute for the invitation. So CEPI, the Coalition for Epidemic Preparedness Innovations, was established in 2017 in the wake of the West African Ebola epidemic, with a mission initially to develop vaccines against emerging infectious diseases. And we're both a what's called a product development partnership, or PDP, which serves to aggregate funds and then establish partnerships with the private sector to develop those vaccines. But we're also a coalition of interested countries, and through the response to the COVID epidemic, the original 6 or 7 countries and a couple of philanthropies that supported us have now expanded to well over almost 30 countries, and additional support from other foundations and even the private sector. After we were established with this mission of developing vaccines against emerging infectious diseases like Ebola, or Rift Valley fever, or chikungunya, to name a couple of other diseases, Lassa fever relevant to the African continent, we actually made a decision, a quite conscious and deliberate decision, to add a second component to our mission statement. So now it's to develop those vaccines and to ensure access for those vaccines for the populations that need them. And that was critically important, because I think access should inform all of the decisions that we make. And we do have the opportunity, as I'll maybe talk about in just a minute, to use our investments in research and development to secure access commitments. And during COVID, in particular, first we recognized the urgency of the situation quite early. By mid-January, really, our read was that we were in an incipient pandemic. And by January 23rd, we had established our first vaccine development partnerships when there were, in fact, fewer than 1,000 cases of COVID documented worldwide. From about March of last year, after we provided funding to initiate vaccine development projects, and we had 9, and I can talk about those if that's of interest. We somewhat shifted our focus to focusing on ensuring access to those vaccines, and we've been working closely with Gavi and with WHO and now with UNICEF to try to create a mechanism to ensure access. And I would say that to date, we obviously have not achieved our ambitions, and I think there are a lot of interesting reasons for why that is. I think we will make a very substantive and substantial contribution to in seeing that vaccines are distributed equitably. But how we got to where we are right now, I think, is an important part of the global story of the response, and I think is already informing discussions, at the UN, at the G7, at the G20, that I hope will lead to the putting in place of the conditions that will allow us to respond more equitably in the future.
Great, thank you, Richard. That was a very helpful context. Perhaps you can help us understand what's happening in terms of vaccine access in Africa in the global context, and the reliance on at least short-term manufacturing in India. And we're hearing even this morning that it may be October before we start to see any real exports from India. Can you help put in context the interconnected nature of the global response?
Sure, and I think it's also important, in recognizing the inequitable distribution that has occurred to date, it is important to step back and realize that it is really almost miraculous that nearly 1.5 billion doses of vaccine have been distributed, essentially just 17 months into an encounter with an entirely new pathogen. Nobody would have predicted that amount of vaccine having been distributed a year or 15 months ago. So that in and of itself speaks to the success of the scientific program. What has not succeeded is the distribution of that vaccine in a equitable way to first protect healthcare workers worldwide and to protect the most vulnerable. So functionally, although we're talking about numbers in the billions, we are still in a situation of vaccine scarcity. And as a friend of mine and member of the CEPI board, Dr. Rajiv Venkaya, puts it, scarcity is the enemy of equity. And the most important way, or one of the easiest ways to overcome inequity is to eliminate scarcity. And of course, what we are seeing is vaccine manufacturers attempting to scale up their production as quickly as possible. But what we are seeing right now is that high-income countries have, used their resources to secure vaccine many-fold over what their populations can possibly use, and unfortunately leaving, comparatively little vaccine for many parts of the world. I think let me step back to what CEPI attempted to do with our vaccine research investments to secure equity, because I think it's an important thing to reflect on as we look towards the immediate future, but also towards the longer term future, which is that in making our investments, we secured access commitments from manufacturers to put what we, at the time, COVAX didn't even exist, what we called the Global Allocation Facility first in line. And through those investments, which totaled about $1.4 billion, we actually potentially have secured, COVAX being the first customer in line for up to close to 3 billion doses in 2021 and 2022. So, I think the lost opportunity of the pandemic was that countries in Europe and in North America that made major investments in funding vaccine development did not use those public sector investments to secure global access commitments. And I think hopefully one of the great lessons learned out of this, will be that we should do that in the future. Just one last final comment. Dr. Ndembe's presentation was a wonderful framing of where we are now. I haven't talked about the challenges of India, but he talked about the challenge of supply, but also the challenges of uptake, which we heard from some of the other speakers about, the challenges of getting to herd immunity. Between the challenges of uptake and the challenges of the supply, possibly getting to herd immunity, and doing that in the context of variants which have increased transmissibility and push that herd immunity threshold even higher. So I think this is a challenge that we're going to be grappling with for, at least several years to come, unfortunately.
Yeah, thank you, Dr. Hatchet. It's I think sobering, but unfortunately an accurate assessment of the situation. You did talk about beyond the supply, some of these challenges, and we heard about that. I want to bring the conversation back to Dr. Farrand and Dr. Omeri to hear from both of you. When the vaccines show up, how prepared are you? What else? You talked a bit about the workforce, the supply chain. How quickly do you think those challenges can be addressed? Are we paying enough attention to the vaccination challenges beyond the supply? What would you like to share with our listeners and our viewers about what else we should be thinking about beyond supply, which of course remains constrained? Dr. Farrand, I'll start with you.
Thank you. Thank you very much. I think that's an excellent question, Dr. Krishna. I think that, yes, I completely agree with what Dr. Ndembe has said around the fact that we need to focus beyond just supplies. I think, just to put things in context, I do want to categorically state that it's very easy to look at the global figures and always mention that things are discrepant and lower in Africa. And I just think that it's important to recognize that the distribution of vaccines has done way better than what was happening, for instance, 20 years ago when we were thinking about distribution of antiretroviral therapy. So things have kicked off really rapidly, and it's a really different landscape, and the global community is paying more attention to the sort of more equitable distribution of vaccines, or indeed a public health intervention. So it's important to start with that so that we don't always paint a gloom picture. And I think institutions such as Africa CDC, etc., are absolutely critical, as are global organizations such as CEPI and indeed the COVAX initiative. So I just wanted to start off with mentioning that. I think that one thing that, at least speaking for Zimbabwe, is an important initiative, important starting point, is that we do have a very strong EPI, or extended program of immunization, set up, and that has provided a template. The other thing is that, once that there's a decision made and there's a very nimble COVID response structure within the Ministry of Health, that things get started very quickly. So if a decision is made today that one is going to vaccinate, you get things rolling very rapidly, rather than lots of red tape and bureaucracy that one has to go through. So that's another good thing. The difficulties are going to be if our focus remains on just vaccine acquisition, because really the one really important issue, which often is not considered in funding, is the operationalization of vaccine delivery. And that includes the sensitization of communities and taking a grassroots approach to, to engage with communities for them to take up vaccines. So I think if our global discourse is all about, we need to either get enough numbers of vaccines, or if we're going to, keep vaccines for dose 1 or dose 2, we're going to miss the boat. There's a huge amount of operationalizing, such as, for example, ensuring that there are enough vaccination cards, that there are enough staff that can be deployed, this transport for staff, not just for vaccines. It's not, again, just about the cold chain. It's about all the logistics, enough fuel, for instance. That bit needs a lot of strengthening, and that costs money. And along with providing money for vaccines, it's important that the operationalization costs. And if I may just add one other thing, is that, yes, there are campaigns, there's information going out, but often those don't match how communities should be communicated with. And there's always been a very vertical, up to down approach of how we should tell communities that they should do this. And I think our approach to community discourse and partnerships and community engagement needs to change very rapidly if we are indeed going to make sure that vaccines are truly accepted by communities. Those I see are the two big challenges in a country such as Zimbabwe. Thank you.
Thank you very much, Dr. Farhan. Very well laid out in terms of some of the other issues that we need to keep in mind. Dr. O'Mary, what would you like to add?
Yeah, thank you so much. I think Dr. Franda has mentioned most of the things which are peculiar to Africa, and Kenya is not an exception. I think going forward, we have to sort the issue of the supply chain, of course. Like right now, there is a lot of uncertainty. Where are we getting our vaccine? Initially, we have been focusing on India, and of course, as we know, India has been facing its own shortages because of the high numbers in India. And therefore, we just need to really come out very, very clearly to look at how are we clearly, which type of vaccine are we having? Because like Africa, we have been relying mostly on AstraZeneca, but then we have to come up with a clear guidelines on which vaccines to get. Because we also know that there are other vaccines which are easier to take, where the uptake is easier, especially the ones that you take single doses. I think that's another direction that we should focus mostly. And I think another way going forward is we have to include COVID vaccine as one of the vaccines that should be part of the primary vaccines. Of course, we don't give it to people below 18 years, but if we made it as a primary vaccine, that whoever goes to hospital, you have to have a certificate and you show that you have been vaccinated or you have not been vaccinated. There are some diseases that have been of global interest, like yellow fever. I think going forward, we should also come up with a way of making COVID as one of the mandatories, even for people who are traveling, so that will encourage many people to take a vaccination. In Kenya, we have got something called community strategy, where we have got people at the community level, that is level 1 of the healthcare system. We believe that when we escalate the vaccination to those levels, which mean that many people will be able to access what everybody wants, just as we want to achieve the herd immunity status for our communities. That's why we want to aim. So if we can be able to get access of vaccines to the lowest possible level of healthcare system, I think that's what we want. We are doing it at the hospital setup. Those people who are outside cannot access vaccines. But also we have to look at the cost, because as we see now, the cost of acquiring vaccines is quite high. Most countries, like in Kenya, like Africa, Kenya, for instance, we rely mostly on donor support to be able to do this, like we were relying so much on Gavi, which supported us largely, despite the fact that also the government of Kenya contributed, but we are relying mostly on donor support. So if we can be able to produce vaccines which are more affordable and efficacious and easy to administer, I think that's the direction we want to take. Thank you.
Yeah. Fantastic. Thank you very much for both of those perspectives. Very important. We're getting great questions and engagement via chat. I'll ask that we continue that as any of our panelists and viewers want to engage through the chat. Please continue that in parallel, because we are going to run out of time here very soon. I do want to switch, because we've had several questions on the very important topic of manufacturing and the recognition that the African continent has very little current vaccine manufacturing ongoing. And this has clearly been noted as a gap in our global system, and one that is already aggressively being addressed both from a global as well as regional level. I want to bring in Dr. Ndembe and Dr. Hatchet to this question. If you can let us know from the Africa CDC, Dr. Ndembe first, what is the approach you've taken? You convened or helped to convene a major conference around African manufacturing. Where do you see this going, and how much of it is feasible in the short term versus long term? And then I'll ask Dr. Hatchet to provide the global perspective as well.
No, great. Thanks. I think that it was really a well-attended conference. Let me just put it that way, or summit with over 40,000 observers, and then the really high-level panelists, including some key outcomes that we have achieved. I mentioned earlier the MOU with CEPI that we're trying out to put it into really implementation. That's the next step. We're working towards that. I think there's a strong political commitment on the continent. That's the first thing that I'm going to bring. I like here. As we speak, there are already discussions across the continent, at least to have at least 5 hubs, at least, if not, on mRNA platform, which is still being investigated and also discussed with partners. And then a second, you've also heard the discussion with WHO around having really hubs around the 5 regions as well to be able to support vaccine manufacturing. I think the goals are there, the targets have been set. We definitely going to, the numbers are there. We import more than 99% of the vaccines. We only produce 1%. I think that's really speaks really high on where we are and what needs to be done. But in the next 5 years, I think we've a very clear framework will be finalized, and then in collaboration with partners, and then we look forward to be able to implement that with all the stakeholders. Thanks, and over to you.
Thank you, Dr. Ndembe. Dr. Hatchet.
No, I'd just like to build on what Dr. Ndembe says. I mean, what the African CDC and the African Union have done is really extraordinary. It also is emblematic of trends that we're seeing worldwide towards the emerging importance of regional efforts. And there's some things that really need to be aggregated at regional scale in order to secure the necessary resources. On the vaccine manufacturing, I couldn't agree more with the African ambitions to increase their self-sufficiency with respect to vaccine. I think one of the secrets to securing equitable distribution of vaccine will be to secure the equitable distribution of vaccine manufacturing. And it was with that intent in mind that we entered into the MOU with the African Union. CEPI doesn't of itself have the resources to finance the construction of new vaccine manufacturing facilities, but we look forward to working with Africa CDC to work on a number of areas related, including, we'll be making investments in innovations in vaccine manufacturing. We're going to be making investments in workforce development. We can provide access to talent and technical know-how to our partners at Africa CDC, and couple our investments in enabling science with the developments of laboratory capabilities and scientific capabilities within Africa. So I do think there will be this a convergence, fortunately, of the emergence of these new technologies and new platforms, particularly mRNA, which actually will allow facilities to work on more than one vaccine at a time and to address local and regional requirements, and thinking in terms of how we can sustain these facilities for the long term so that they're there when we need them, when we face future epidemics and pandemic threats, will be critically important.
Great. Yeah, thank you, Dr. Hatchet. That raises several questions which we could spend another hour going through, but unfortunately we are very close to our time, and I want us to maybe pull back and end. I'm going to come to each of you for a brief parting thought, especially in the context that we're coming upon a season where many world leaders will be coming together really to take stock of the past year and how we move forward. We've got the G20 Global Health Summit, we've got the World Health Assembly, we've got the G7 Leaders Summit, all coming up in the next month. And so maybe I would ask each of you to share a comment or a single point you'd like to make briefly about what do you think is the most important thing that globally we can ask our leaders to focus on to make sure that we're moving toward greater access and more equity, especially as it relates to vaccines. And Dr. Hatchet, I'll start with you.
Well, I would say that there are a number of steps that we can take to increase vaccine manufacturing and to lead to greater equity in vaccine distribution. There's been a lot of attention, of course, on the U.S. changing its position around the TRIPS waiver for intellectual property waivers, and I think that sends a tremendously important signal that business as usual is not good enough given the emergencies that we face. But I would not want it, because that's a longer term solution that may increase vaccine supply next year and then the year after. But I would not want it to distract attention from things that can be done right now, including securing the supply chain for manufacturing of vaccines and including dose donations from high income countries that could help us in the very near term.
Fantastic, thank you. Let me go next to Dr. Farrand.
Thank you, Dr. Krishna. I think I'm going to slightly digress to say that it is very important for the global community to not think of vaccines as the panacea for controlling the COVID pandemic. I remain concerned about the fact that the discourse has, whilst it's incredibly important to focus on the different aspects of vaccines, there will need to be a continued sort of public health investment as well as sort of a resource investment to maintain other arms of control of the pandemic. And one area, particularly speaking for the continent, that will need investment is management of COVID. Even though the numbers of cases and deaths has been far lower, that prevention and other public health measures as well as care for patients will need to be scaled up. And when I mean care, I mean it in the broadest sense, in terms of making sure that health systems are strengthened so that the impact of the indirect impacts of the COVID pandemic do not sort of destroy the achievements we've made in health programs. So that's kind of my one message to the international community. Thank you.
Fantastic. Thank you. Let me go next to Dr. O'Mary.
Yeah, thank you so much, Krishna. First of all, I want to appreciate this forum, this discussion. It has been very, very helpful and very productive. I want to say that globally, we need to focus on more research, especially in the area of COVID. We know that we have had various forms or variants of COVID coming up now and then. So there is need to really increase more on research to be able to get to know all the mutation types of COVID-19. And then secondly, of course, just like my colleagues have spoken, globally, nations need to allocate more resources to combating COVID. These resources will be used both in terms of providing those basic preventive measures, as we have mentioned before, hand washing facilities are still very, very crucial. And then, of course, we want to, we suggest that globally, the production of vaccines should be enhanced so that all areas, all countries, and even continents like Africa, we should have centers where we are producing enough vaccines to make sure that there is a continuous supply. And of course, training of healthcare workers and other people needs to be enhanced. And now that COVID is here with us, you know, when it started, we thought it's something that is going to be there for a few days and go away. But as we can see, it is going to be here with us for some time. And therefore, we have to put up all institutions that are able to fight this. In fact, I want to suggest, like in Africa, you find that the existing systems are not very perfect. We are very fortunate that we have not had a very bad experience like Brazil, India, and even the US, who have better systems. I always think that if we had the same challenge in Africa, I think it would be much more disastrous. So Africa needs to put up more centers like infectious disease centers that can be able to cater for emergencies like the COVID with all the necessary equipment. Of course, we want all, the interest here is to prevent us going to those isolation centers, but it's very, very important that in case people get affected, we have to have a place to take care of them. I think generally, I would like really to appreciate sharing more on this forum, especially in issues of global matters, not just only COVID, but all other issues that are really informative to us, especially from this part of the world. Thank you so much.
Fantastic. Thank you so much, Dr. Omeri. The final word I'll give to Dr. Ndembe.
No, thanks so much. I think two things. I think we've mentioned the vaccine manufacturing is one of those that really would like to see moving forward on the continent. I think this is a wake-up call for the continent. I think we need to take this, and then using Africa CDC and African Union combining power to drive this initiative. As you're aware, we've launched the Partnership for African Vaccine Manufacturing. It's a call also for more partnership to address that. And then second, research and development. It's very important as we move forward. The next generation of vaccines we did mention, but at least we may have to deal with the new variants, vaccine efficacy, coverage. I think those are critically important to reach what we've said, herd immunity. It's quite challenging at this time, but putting all together our effort in a global collaborative way, communications and collaborations, we should be able to achieve that. Thanks. Nothing is impossible until it's done. Thank you. Now over to you.
Thank you so much, Dr. Ndembe. That just leaves me to thank all of our fantastic speakers, Dr. Farhan, Dr. Omeri, Dr. Hatchet, Dr. Ndembe. Thank you so much, both for joining us, but also for the amazing leadership you're providing to address all of the challenges we're facing today. Please do stay in touch, much more to come. And I want to thank all of my colleagues across Duke for making this whole series possible. Dr. Carrie Stewart, Shivani Surati, Lee Walls, our communications team with Michael Penn, with Melissa Slogan, Dr. Shenglin Tang for leading this effort across the Institute. We're certainly not done with talking about COVID nor leading efforts to address it. So please stay in touch. Please continue to build this community, and very good morning, afternoon, and evening to you all.